Thanks again, Colette. As she said, I'm working on my PhD up at University College Dublin. And the piece that I'm going to share with you today is part of what's been kind of a qualitative community health needs assessment. And this piece is looking at the perspectives of experts who are working in the homeless health and addiction services on what they view as the priority healthcare needs amongst people experiencing homelessness in Dublin. And we were also able to talk to service users, and I have the privilege of being able to give a brief lightning talk about what the service users felt later this afternoon. And kind of the idea behind the project is that, of course, we know, as was just mentioned in the main talk, that the health inequalities that are already existing were exacerbated during the COVID-19 pandemic. But the good news, many of you may be familiar with the fact that in the Republic of Ireland, most of the levels of homelessness are concentrated in the city centre. And for the past many years, in fact, there's been this network of open access primary care and addiction services set up in the city centre, so that today, in fact, access to primary care and access to harm reduction is pretty exceptional in this area. And so our idea was to go in to this area where we know that access to primary care is pretty good and see what providers thought about in terms of next steps. So we did purposive and snowball sampling of people working in the area, and then we're able to do semi-structured interviews with them between September of last year and March of this year, asking them questions about what they felt were the priority areas for action, how they saw people in homelessness using and accessing the services, and then where may be gaps in those services and where might there be gaps in the research. And then once those interviews were complete, we were able to do inductive thematic analysis of the interview transcripts. So 19 people were generous enough to talk with us. We were able to capture some voices from the homeless health services, from addiction services, a few representatives from the HSC, some researchers, hospital perspectives. But of course, we're here to talk about what they actually said. So when we did that inductive thematic analysis of the priority needs, there were 5 themes or 5 overarching themes that emerged that I'll just go through briefly today. The first is taking place at more of a policy level, and experts were saying, as is really the theme of this conference, we have to accelerate our action in addressing health inequalities. And the sub-themes came through, apologies because there's a lot, but they're just listed at the left there. But it starts with, in terms of what they were saying, a more strategic approach, because it seems that in Ireland, there's a tendency to rely more on reactive policies, maybe once a crisis is already happening, and the idea is to get on the front end of those crises. And that part of that involves better interagency collaboration, because there has been significant improvements. But providers really felt that mental health, homeless health services, housing services, and addiction services continue to operate in silos, at least in Dublin City. Something that might help in terms of collaboration is better data sharing and linkage, specifically a faster rollout of the individual patient identifier, because oftentimes when people present to care, their care is restarted because it's hard to know what has happened before they're showing up at the door somewhere. And then it's not as fun of a concept, but participants were also saying, we're not actually that good at monitoring to make sure that the supports that clients are said to be receiving, they are receiving, and that that's standardized between different agencies and services. And of course, all of this coupled with the fact that we can't ask people to think about their health until they have safe and stable housing in which to be able to do that. Probably you can hear the siren behind me, sorry for that. Participants were talking about a need for better social support options in light of the fact that in Ireland, we also tend to have a perhaps over-medicalized response to homelessness and addiction, and aren't always particularly good at looking at the underlying causes of the issues, things like loneliness and neglect. And, maybe it's idealistic, but this idea of redirecting funds towards stronger community development, or even more simply just spaces where people can come together and meaningfully socialize with one another. And as we know in public health, it's important not just to try and fix what's bad, but to feed what's good as well. And in this cohort, there's an enormous amount of good. People in homelessness are incredibly resilient. There's a lot of creative problem solving, a lot of humor actually, and altruism. So to really keep those qualities in mind as we implement programs. The second theme that came through was at the level of the health services. And there we have to continue working towards removing the barriers to access that exist. Participants mentioned a critical shortage. Well, in certain areas, we know that they affect the entire population, but of course, these factors trickle down to affect the people who are more vulnerable. But we know that currently there's a critical shortage of mental health beds and professionals. We know that there's a critical shortage of residential stabilization and treatment beds for addiction, and that this particularly affects pregnant women. And we also know that there's a saturation of GP services, which means that even when someone in homelessness manages to find stable housing, perhaps they're stabilized in their addiction, because there's no space in kind of the mainstream system, it's hard to step back into that mainstream care at the minute. Of course, we have to think about safety. When we think about homelessness and participants, we're hoping to see that safety continue to be embedded into the low threshold services that are available, keeping in mind that it's important to continue to create women-specific services. In terms of care pathways, dual diagnosis was mentioned, which, if you're familiar with, is the concept that someone who has both mental health and addiction challenges tends to fall between the cracks of those two services. But something that I hadn't heard as often is that currently there's some crisis points that are going undetected when people present to care. And the ones most mentioned were after experiences of sexual or gender-based violence. They were relating to the issue of repeat overdose, and also for women whose children are taken into care. And what's happening is that it's hard to screen for these really traumatic events. And it's also, there's not necessarily a great follow-up pathway in place. And participants were hoping to see better screening and pathways in future. And one element that might help with that would be to make sure that the healthcare professionals across the board, from the highest to lowest levels in any service, are really prepared to provide trauma-informed care, because participants reminded that as much progress as we've made, stigma continues to exist in the healthcare setting. I had said it's important to focus on the strengths. So in terms, there's a lot of good things that are happening, but two that were mentioned are the hospital-based inclusion health teams that exist in Dublin, which are located in 2 inner city hospitals where they're prepared to provide care that's really related to the complexity of the lives of people in homelessness. They don't stick to really strict appointment systems. They're prepared to accept people with a cup of tea even. And these really catered teams are helping reduce repeat attendance to hospital, which is fantastic. And another good program that was mentioned was the hepatitis C outreach program, which for several years has been sending peer support workers out into the community to test and diagnose for hepatitis C and then link with treatment. And participants were saying, what would it look like if we started to talk about expanding that type of outreach program, but for longer term conditions, things like epilepsy or respiratory illness, which are so prevalent amongst people experiencing homelessness and addiction. The third theme has to do with knowledge gaps. Where do we need more research? The issue of addiction care and support is very complex, and some questions arose in terms of how we're prescribing methadone and how to navigate the fact that generally people in homelessness don't sleep very well and may rely on medications for those. So it's definitely an area that deserves more attention. Something else that came through is that there are groups within which the levels of homelessness are rising really rapidly and not necessarily related to addiction. And that would be amongst migrants and asylum seekers arriving in Ireland. It would be amongst older people who maybe because of dementia are forgetting to pay their rent and being forced into homelessness. And then we also have the issue of young adults who are leaving foster care straight into homelessness. And so that would be 3 groups that experts said we really need to make sure that we know sort of what's happening within these populations. The fourth theme that came through, which is so important, is this idea that, we can change the services as much as possible, but really to move towards health equity. And I think it relates to the keynote speaker this morning in more of the policy context or the political context, but we have to make sure that we're actually working towards having a culture that values health equity, and that this requires some type of societal shift in our understanding of homelessness and addiction, which more widely takes blame away from the people who are experiencing those challenges. You know, the idea that we have to give the most to the people who need the most, you know, it's not totally widely accepted, even though I would imagine it is amongst the people who are here today. And then finally, of course, we have to include homeless service users in health and social service design and planning delivery, especially because at the minute there are very few opportunities for exchange between the people making the policies and then service providers and service users. One participant saying that we actually don't have a lot of data about how people are in homelessness would like their healthcare, so that obviously we're not just making all the decisions for them. I think that that's actually the subject of one of the talks coming later in this session, so that's really exciting to hear. And then, like I said, I was able to talk to some service users about what they thought about their own health and healthcare, of course. And so that's going to pop up today during the lightning talk. So the information is all available if you want to follow that link, and then please feel free to ask via email or the question and answer. Thank you.